Welcome back to the Physiotherapy Clinical Edge. Today I am back with a fantastic case study of a knee pain patient, and in this case study I'm going to walk you through this person assessment, the findings and the diagnosis, and also I'm going to walk you through the evidence-based rehabilitation plan that we're going to design for this person. And I would really advise you to utilize your clinical reasoning skills and also consider the diagnosis that pops up in your mind while you're watching the video. So if this sounds really great for you, let's quickly dive into the case study without any further delay. So in this case study, we're gonna see an young athlete who is presenting with anterior knee pain. As a physiotherapist, I believe it's really important to consider our findings from our subjective and objective assessments and make up that likely diagnosis and design an effective rehab plan for that patient. And our patient here is an 25-year-old male, an uni student who actively participates in the basketball. So he presents with this left-sided anterior knee pain, which has been affecting his ability to attend the training sessions and the matches. So the symptoms started approximately 4 months ago after participating in the university sports, especially in the basketball. So interestingly, the pain is worse at the beginning of the game, but it eases slightly as the activity continues. So this is often referred as a warm-up effect. So he reports no pain during walking or stair climbing or descending. So his past medical history is unremarkable. It's no complaints and there is no red flags that we should be concerned about, so which is a good news. And now let's look into the objective findings for this patient. So on observation, the patient demonstrates a normal gait pattern without any pain. He walks independently to the clinic. So there is no visible swelling or bruising, deformity around the knee joint that we should be concerned about. And on palpation, he reproduces the pain, especially at the inferior pole of the patella. So both active and the passive range of motions are full and pain-free at the hip and the knee joints. So the strength overall is very good and normal. However, the resistant knee extension is reproducing the pain in the quadriceps mechanism. So there is also a mild weakness is noticed at the hip abductors. On functional testing, including a single leg decline squat and hopping on the affected leg, successfully reproduce the patient's symptoms. The one particular useful assessment for patellar tendon disorders would be the single leg decline squat, because this decline position really increases the load on the patellar tendon and reproduces the patient's symptoms, and which makes it more sensitive functional test. So in this case, the patient's pain is reproduced during this movement, providing a very important clue towards our diagnosis. Now, at this stage, if you like, you can pause the video, and based on our subjective history and objective findings of the patient, you could really think of what would be the likely diagnosis for this patient's condition. And I would suggest you to think of the key features that we have seen in their histories and the findings, and consider the diagnosis that comes up in your mind and make a note of it before you continue watching the video. And the diagnosis is Patellar tendinopathy, or which is also referred as jumper's knee. So this condition is very frequently seen in sporty individuals. That includes repetitive jumping and landing, sprinting, and rapid changes in the direction of the knee. In this condition, the patellar tendon becomes overloaded over time and results in that pain and reduced tolerance, the load tolerance at the knee. So why is this diagnosis? Let's look at the reasoning behind giving this diagnosis. So when we see the subjective assessment of this patient, we have this young active male involved in basketball, a sport that places significant repetitive load on the patellar tendon. And also in the history of this patient, it reveals there is increased tendon loading through jumping and explosive sporting activities. Another important clue that we can see from the patient's subjective history would be the warm-up response. The patient complains that the pain is more worse initially when he begins the game, and it gets easier when the activity is continuing. So, and the absence of the symptoms with low loading activities like walking and stair climbing also adds an even more important important clue that it might be a tendon-related issue. We have a localized tenderness, especially at the inferior pole of the patella, and reproduce of symptoms during tendon loading activities with the functional tests. So together, all these findings strongly suggest that it is patellar tendinopathy. The successful rehabilitation requires careful tendon load management, then complete rest. So there are a few things that we have to bear in mind before we initiate a rehab program on our patients. The patients has to warm up before the training and also should avoid unnecessary increasing in training volume or intensities and loading more weight on their knees. And also we often consider doing the exercises with mild discomfort. As far as the pain range falls at 3 out of 10 in the pain scale, it's okay to continue doing the exercises. When the pain exceeds then this level, it indicates a requirement for changing or modification in the treatment plan. So the goal is gradual progression while maintaining the tendon adaptation. So there is a recent research that highlighted the benefits of isometric exercises at the early stages of rehabilitation of patellar tendinopathy. So the isometric leg extension holds performed at least for 45 seconds really improves the symptoms of pain and increase that tendon load tolerance at the patella. So the early rehabilitation should really focus on controlled loading then complete unloading. So when the patient really progresses, they can really move forward to more dynamic sport-specific activities. And these approach prepare the tendon for the demands of returning to sport. So at the early stages of rehabilitation, we should always aim for pain management during first 2 weeks of the patient rehab program. The key exercises includes isometric quadriceps contractions, wall sets, straight leg raises, hip abduction exercises, and low resistance cycling. The goals are to reduce pain, maintain strength, and improve tolerance to loading. Once symptoms begins to settle, we can progress into stage 2. These stages focus on improving the tendon capacity through exercises such as decline squats, step-ups, lunges, and bridges, and the calf raises. Progression should always be guided by the symptom response and the movement quality. And stage 3 focus on building strength and power. The exercises become heavier and more demanding, including weighted decline squats. Exercise become heavier and more demanding, including weighted decline squats, single leg press, split squats, Romanian deadlifts, and the core strengthening exercises. The aim is to restore maximal strength and prepare the athlete for plyometric activities. Stage 4 introduces plyometric training and returning to sport preparation. Exercises include hopping drills, lateral jumps, depth jumps, and sport-specific movement training. As we all know that before they return to full participation, the athlete should demonstrate minimal pain, good confidence, good functional performance, then compared to the unaffected side. That's the end of the video. Thank you so much for watching this knee pain case study, and I hope you find it really helpful in understanding how to identify and manage the patellar tendinopathy with more structured clinical reasoning approach. So if you find this really helpful, save it and share it with your friend, and follow for more such physiotherapy clinical content, and bye for now.